My name is Dzul, and I'm presenting my project, which utilizes a customized anthropomorphic chest phantom, which I'll show in a second, to validate the amount of radiation going to the heart in a simulated course of tangential breast radiotherapy. So radiation treatment is widely utilized in the management of breast cancer, and it has been now for over 50 years. Now, as we've improved our management of breast cancer, the majority of our patients they do very well, and they're actually very likely to be cured of their breast cancer. And as a result, although they are cured of cancer, they do have to live with the long-term sequelae of our treatments. As we've studied more and more long-term breast cancer survivors, there has been many studies have shown now that there's an increased risk for cardiovascular disease, which correlates with the amount of radiation which is received by the heart. So in response to these studies, now with modern radiation techniques, we put a lot of effort in to try to treat the breast while sparing the heart any significant amount of radiation. And in fact, our most recent guidelines now recommend a heart dose constraint as low as 70 centigrade. Now, meeting this very tight constraint is challenging. It requires complex treatment planning techniques, and in some cases, sacrificing the target that we're actually trying to treat, which is the breast. The treatment planning software we use, though, to predict the radiation, where it goes, it's not very good at predicting where radiation goes to things that are outside of our field. And there's several studies which have shown that as well. So the purpose of this study was to use a customized anthropomorphic chest phantom to compare the amount of radiation going to the heart on our treatment planning software versus what we measure in our phantom. So we purchased an anthropomorphic chest phantom, which is shown, a model is shown here on the right. This is a phantom that is intended for diagnostic imaging purposes, and we repurposed it here for therapeutic radiation purposes. It's made of CT tissue equivalent material. There is a removable heart and lung, which we placed OSLDs, which are essentially small devices which can measure the amount of radiation going to each particular position. And we placed these OSLDs around the heart. We then did a simulated course of whole breast radiation on this phantom. And then after doing the simulated course of radiation, we removed the OSLDs and measured how much radiation went to each respective position. Finally, we compared the amount of radiation that we measured versus what was predicted on our treatment planning software. These are the 9 locations that we placed the OSLDs on around the heart. They're shown here. There's a 9th one not shown on this figure, which is on the chest wall surface, which is out of field on the contralateral side of the patient, which is the right side. Figure 3 contains representative CT images from the simulation that we did of our phantom, which shows our intended radiation treatment plan with a predicted dose distribution. This plan was designed to mimic one of our typical breast radiation treatments for one of our patients in the clinic. Table 1 of our results is a comparison of the treatment planning software predicted dose versus the measured dose in our phantom. We found that 4 of the 9 positions were accurately predicted, and 5 of the 9 positions, the treatment planning software actually underestimated dose. That includes to the left anterior descending artery, the right ventricle surface, the right heart surface, the inferior heart surface, and then the chest wall out of field. Figure 4 is a bar chart, which essentially is a graphical depiction of the data in table 1. As you can see, here we have 4 of our predicted, 4 of our locations. The treatment planning software accurately predicted the measured radiation dose within the 99% confidence interval. However, there were these 4 locations denoted by an asterisk where the treatment planning software underestimated the heart dose. Now, wrapping up our results, when we looked at our simulated plan on the treatment planning software, there was a predicted mean heart dose of 122 centigrade, which is very similar to our heart dose constraint. If we extrapolate from the increased dose that we measured in half of our OSLD positions in the phantom, we think that the actual mean heart dose may be as high as 18 centigrade higher than predicted by the treatment planning software. Now, when we take some numbers from the literature, such as there's assumed to be a linear correlation between the amount of radiation absorbed by the heart and the risk for coronary heart disease of 7.4% absolute increase in risk per absorbed gray mean heart dose. This would correspond with an increased lifetime risk for coronary heart disease of 1.3% above that predicted by the treatment planning software. So to conclude, our treatment planning software that we use, Eclipse, it may underestimate dose to the heart in our typical hypofractionated tangential breast radiation treatments. We see the greatest relative difference at areas of the heart which are furthest away from our field, which include the inferior and right surface of the heart. Because our treatment planning software is likely under predicting heart dose, we think it's even more important to continue to utilize complex treatment planning techniques to reduce heart dose, including multi-leaf collimator heart blocking, inspiratory breath hold techniques, and IMRT plans to avoid the heart as much as possible. We do need to do additional work to assess how these changes in these locations affect mean heart dose, because really what we're only measuring is just dose in these specific locations, not within the heart, just around the heart. So that may be limiting our results here.